Welcome to the virtual Neuro Review. This will be a review of the neurological topics, Neuro Assessment, continuing on and ending with Guillain-Barré. The objectives for this lesson include the objectives we've been working on all along. Assessment, identify basic neurological assessment, abnormal and normal. Communication, how do we utilize SBAR format and information technology to support and communicate a plan of care for the client with neurological changes? Caring interventions, how do I identify nursing care for clients with neurological or sensory deficits? Clinical decision making, identify and discuss nursing priorities appropriate for the client with neurological or sensory deficits. Teaching learning, identify appropriate teaching priorities for the client and the family with neurological deficits. Further objectives include collaboration, identify and collaborate with members of the healthcare team to provide resources for the client with neurological deficits. Think about who you need to collaborate with these specific types of clients. Managing care, identify management strategies of the client with neurological deficits considering financial reimbursement. This is where the case managers get involved. So what is the purpose of our neurological assessment? The purpose of a neurological assessment is to detect neurological disease or injury in your patient, monitor its progression to determine the type of care you'll provide, and gauge the patient's response to intervention. Performing a neurological assessment early is important in establishing a baseline for later comparison. Our initial neurological assessment is our most important, as it gives us a baseline for further evaluation of neurological changes in the client or patient. The initial evaluation is usually a comprehensive examination covering several critical areas of assessment, including level of consciousness, orientation, speech, facial symmetry, motor and sensory function, and reflex activity. Assessment of cranial nerve function, cerebellar function, and reflex activity are covered in a comprehensive neurological assessment. Before beginning a focused neurological assessment, an evaluation of the patient's vital signs should be conducted, as current or progressive injury to the brain and brainstem may make vital signs unstable, which could reduce neurological responses. It is best to conduct the neurological assessment at a time when vital signs are relatively stable. Obviously, we will continue to evaluate our patient in a timely fashion and denote any changes in vital signs. Level of consciousness. Level of consciousness by far is the most important part of the neurological exam, as a change is usually the first indication of a declining neurological status. The Glasgow Coma Scale, GCS for short. The Glasgow Coma Scale is a valuable tool for recording the conscious state of a person and is based on 3 patient responses: eye-opening, motor, and verbal response. The total score will range from 3, the patient is in a coma, to 15, the patient is fully conscious, alert, and oriented. A score of 8 or lower usually indicates a coma. Although the Glasgow Coma Scale was initially used to assess level of consciousness after head injury, it was not designed to be used for patients who are intubated, as the verbal component of the score cannot be accurately assessed. In documenting the Glasgow Coma Score for intubated patients, a notation of the patient's intubation can be included as a narrative note to facilitate accurate interpretation of the Glasgow Coma Scale score. A bedside assessment of neurological assessment almost always includes an evaluation of motor and sensory function, but requires the patient to be cooperative and oriented. To assess motor response in a comatose patient, apply a painful or other noxious stimulus to a central part of the body, such as the trapezius muscle, squeezing or application of supraorbital pressure. Then observe for specific motor responses as specified in the Glasgow Coma Scale, such as flexion to corticate posturing or extension motor responses to cerebrate posturing. Cushing's triad, not to be confused with Cushing reflex, is a sign of increased intracranial pressure. It is the triad of hypertension, bradycardia, and widening pulse pressure, an increase in the difference between systolic and diastolic pressure over a period of time. Cushing's triad suggests a cerebral hemorrhage in the setting of a trauma or a space-occupying lesion that is growing and is possibly impending fatal herniation of the brain. Cushing's triad is named after an American neurosurgeon, Harvey Williams Cushing. This, again, is an abnormality in the neurological patient. Other abnormal assessment findings include posturing. Decerebrate posturing indicates damage of the upper brainstem. Decorticate posturing indicates cerebral dysfunction. Increased intracranial pressure is a cause of decortication and decerebration. Alterations in sensation or paralysis indicate dysfunction in the spinal column. Look at your previous lectures, such as neurological assessment, for pictures of decerebrate and decorticate posturing. Further abnormal assessment findings include visual field changes, homolymous hemopsia. The patient presenting with this loss of half of the visual field turns away from the affected side of the body and tends to neglect that side and the space on the side. This is called amorphosynthesis. In such instances, the patient cannot see food on half of the tray and only half of the room is visible. It is important for the nurse to remind the patient constantly of the other side of the body to maintain alignment of the extremities and, if possible, to place the extremities where the patient can see them. Abnormal assessment continued. Homolymous hemopsia. Patients with this problem are unable to perceive objects to the side of the visual midline. The visual loss is contralateral. It is on the side opposite the brain lesion. To facilitate self-care, commonly used articles such as the water pitcher, meal tray, and call bell are placed on the unaffected side. The patient should be approached from and communicated with while standing or sitting on the side in which vision is best. When in visual contact with the patient, caregivers should move slowly toward and past the visual boundary to stimulate scanning to the affected side. Auditory and visual stimulation on the affected side can help improve and maintain residual sight on that side. Fixed or dilated pupil. A fixed and dilated pupil is a very serious sign of a brain injury. It is also a late sign of a brain injury, meaning that there are other neurological changes, decrease in the level of consciousness, behavioral changes, confusion, weakness or paralysis before the brain injury progresses to where the pupils are fixed and dilated. Generally, a fixed and dilated pupil means that either brain swelling or bleeding in the brain has progressed to where there's pressure on the oculomotor nerve, cranial nerve number 3, and it does not allow the eye to react to light. This is a very serious situation and is usually a sign of cerebral herniation and indicative of impending death unless drastic action is taken. Further abnormal assessment. Brain failure. As a type of organ system failure, brain failure invariably affects consciousness. Consciousness is structurally produced in the cerebral hemisphere, including the pons and the medulla. These structures are all interconnected by the reticular formation, which begins in the medulla and extends to the midbrain, where it forms the reticular activating system. This pathway modulates the perception of events and controls integrated responses. Finally, abnormal assessment, brain death. Known nature of the coma. There is no evidence of cerebral or brainstem function for 6 to 24 hours per the EEG. There's a normal body temperature. There are no depressants, drugs, or alcohol on board. Complete unresponsiveness. There is absent motor and reflex movements. pupils are fixed and dilated, apnea, and lack of cerebral circulation are some further assessment findings. Review of head trauma. Traumatic brain injury, or TBI, continues to be an enormous public health problem, even with modern medicine in the 21st century. Most patients with TBI, 75 to 80%, have mild head injuries. The remaining injuries are divided equally between moderate and severe categories. Cost of traumatic brain injury. The cost to society of traumatic brain injury is staggering from both an economic and an emotional standpoint. Almost 100% of persons with severe head injury and as many as 2/3 of those with moderate head injury will be permanently disabled in some fashion and will not return to their pre-morbid level of functioning. In the United States, the direct cost of care for patients with traumatic brain injury, excluding inpatient care, is estimated at more than $25 billion annually. The impact is even greater when one considers that most severe head injuries occur in adolescents and young adults. Statistics. The annual incidence of traumatic brain injury in the United States has been estimated to be 180 to 220 cases per 100,000 in population. In the United States, with a population of almost 300 million, approximately 600,000 new traumatic brain injuries occur per year. As many as 10% of these injuries are fatal, resulting in an almost 550,000 hospitalized annually in the United States with head injuries. Mechanisms of traumatic brain injury. While various mechanisms may cause traumatic brain injury, the most common causes include motor vehicle accidents, example, collisions between vehicles, pedestrians struck by vehicles, bicycle accidents, falls, assaults, sports-related injuries, and penetrating trauma. Motor vehicle accidents account for almost half of the traumatic brain injuries in the United States, and in suburban rural settings they account for more or most traumatic brain injuries. In cities with populations greater than 100,000, assaults, falls, and penetrating trauma are more common etiologies of head injury. The male to female ratio for traumatic brain injury is nearly 2-to-1, and traumatic brain injury is much more common in persons younger than 30 years of age. Appropriate management of traumatic brain injury requires an understanding of the pathophysiology of head injury. In addition to the obvious functional differences, the brain has several features that distinguish it from other organ systems. The most important of these differences is that the brain is contained within the skull, a rigid and inelastic container. Because the brain is housed within this inelastic container, only small increases in volume within the intracranial compartment can be tolerated before pressure within the compartment rises dramatically. This concept is defined by the Monroe-Kell doctrine, which states that the total intracranial volume is fixed because of the inelastic nature of the skull. Monroe-Kelly hypothesis, compensatory mechanism. As the volume of one of these fluids increases or decreases, there is a reciprocal change to balance and maintain intracranial pressure within normal limits. The three components consist of brain tissue, which is 80%, plus blood, which is 10%, plus CSF, which is 10%. Pathophysiology. In the typical adult, the intracranial volume is approximately 1,500 mLs, of which the brain accounts for 85 to 90%. Intravascular cerebral blood volume accounts for 10%, and cerebral spinal fluid accounts for the remainder, about 3 to 10%. When a significant head injury occurs, cerebral edema often develops, which increases the relative volume of the brain. Because the intracranial volume is fixed, the pressure within the compartments rises until some compensatory action occurs, such as a decrease in the volume of one of the other intracranial components. This is intimately related to the concept of intracranial compliance, which is defined as the change in pressure due to change in volumes. Pathophysiology continued. Our second crucial concept in traumatic brain injury pathophysiology is the concept of cerebral perfusion pressure. Cerebral perfusion pressure is defined as the difference between the mean arterial pressure and the intracranial pressure. In practical terms, cerebral perfusion pressure is the net pressure of blood delivery to the brain. In the non-injured brain, in individuals without long-standing hypertension, cerebral blood flow is constant in the range of mean arterial pressure of 50 to 150 millimeters per mercury. This is due to autoregulation by the arterioles, which will constrict or dilate within a specific range of blood pressure to maintain a constant amount of blood flow to the brain. Categories: traumatic brain injury. Traumatic brain injury may be divided into two categories: primary brain injury and secondary brain injury. Primary brain injury is defined as the initial injury to the brain as a direct result of the trauma. This is the initial structural injury caused by the impact on the brain, and like other forms of neural injury, patients recover poorly. Secondary brain injury is defined as any subsequent injury to the brain after the initial insult. Secondary brain injury can result from systemic hypotension, hypoxia, elevated intracranial pressure, or as the biochemical result of a series of physiologic changes initiated by the original trauma. The treatment of head injury is directed at either preventing or minimizing secondary brain injury. What is intracranial pressure? Intracranial pressure is the pressure within the cranial cavity. It is measured within the lateral ventricles. The normal range is 10 to 20 millimeters. Better prognosis if kept under 15. Transient increases not harmful. Sustained increases equal ischemia and tissue death. Increased intracranial pressure. Elevated intracranial pressure may result from the initial brain trauma or from secondary injury to the brain. In adults, normal intracranial pressure is considered 0 to 15 millimeters per mercury. In young children, the upper limit of normal intracranial pressure is lower, and this limit may be considered 10 millimeters of mercury. Elevations in intracranial pressure are deleterious because they can result in decreased cerebral perfusion pressure and decreased cerebral blood flow, which, if severe enough, may result in cerebral ischemia. Severe elevations of intracranial pressure are dangerous because, in addition to creating a significant risk for ischemia, uncontrolled intracranial pressure may cause herniation. Herniation involves movement of the brain across fixed dural structures, resulting in irreversible and often fatal cerebral injury. Manifestations of increased intracranial pressure: headache, nausea, vomiting, altered level of consciousness, memory, speech, drowsiness, agitation, restlessness and/or loss of judgment, Cushing's triad, change in vital signs, increased systolic blood pressure, widened pulse pressure, bradycardia, altered respiratory patterns, deep respirations. Increased intracranial pressure. This is a little cartoon to describe changes in increased intracranial pressure. For example, changes in level of consciousness, the eyes showing papilledema, pupillary changes, impaired eye movement, possible posturing, decerebrate, decorticate, or flaccid, signifying brainstem dysfunction, decreased motor function, changes in motor ability, posturing, again, a late sign of increased intracranial pressure. Headache, seizures, impaired sensory and motor function, changes in vital signs, Cushing's triad, increased systolic blood pressure, decreased pulse, altered respiratory pattern, possible vomiting, changes in speech, such as slurred speech. In infants, particularly, bulging fontanelles, cranial suture separation, increase in head circumference, high-pitched cry. Child is inconsolable. Epidural hematoma, a specific type of traumatic brain injury, occurs mainly young to middle-aged adult, related to skull fractures, possible torn artery, meningeal injury is most common, rapid onset, associated with a headache, loss of consciousness, awake, and then loss of consciousness occurs. Fixed dilated pupil on the same side of the hematoma. To continue with epidural hematoma, contralateral hemiparesis or hemiplegia, possible seizures. You want to prevent herniation of the brainstem. Possible surgical intervention here, such as evacuation or a burr hole. Monitor for signs and symptoms of increased intracranial pressure, and also monitor directly for intracranial pressure. Subdural hematoma, localized mass of blood between dura mater and arachnoid space. It is more common than epidural hematoma. It is caused by direct trauma. Indirect trauma can also cause this, such as shaking baby syndrome. Acceleration, deceleration injuries, as those that occur in a motor vehicle accident when somebody is not wearing a seatbelt. Just a regular motor vehicle accident can cause this. Tears in veins, treatment is with a burr hole. Subdural hematoma, acute subdural, rapid onset, drowsy, confused, ipsilateral pupil dilation, unilateral headache, hemiparesis, respiratory complications, chronic subdural, weeks to months before symptomatic, may be spontaneous in older adults or patients with bleeding disorders, slow cognition, confusion, drowsy, ipsilateral sluggish pupil, possible seizures. A CAT scan is a diagnostic study of choice in the evaluation of traumatic brain injury because it has a rapid acquisition time, is universally available, and is easy to interpret and is reliable. This is a slide that speaks to the diagnosis and treatment of increased intracranial pressure in addition to the assessment and risk factors. Review this slide. It pulls the whole concept of increased intracranial pressure together. Intracranial surgery utilized to decrease intracranial pressure. Craniotomy, burr hole, or craniectomy, used for brain expansion and or removal of hematoma. Approaches: supratentorial, above the tentorium; infratentorial, below the tentorium; transsphenoidal, approach through the mouth and nasal sinuses, used to access the pituitary. Complications or outcomes of surgical procedures. Complications: there are many possible. Example: neuro impairment, infection, seizure, neurological deficiencies. Post-op care depends on neurostatus. Prevent complications, maximize cerebral function, support other systems are some of the goals after surgery. Outcomes: intracranial pressure will remain in recommended range. Client will be able to perform activities of daily living independently or with assistive devices. The outcome of traumatic brain injury is related to the initial level of injury. While the initial Glasgow Coma score provides a description of the initial neurologic condition, it does not correlate tightly with outcome. Various methods have been used in an attempt to predict the outcome of traumatic brain injury, and these are beyond the scope of this discussion. However, one simplified model uses 3 factors, that is age, motor score of the Glasgow Coma Scale, and pupillary response: normal unilaterally unresponsive pupil, bilateral unresponsive pupil, to provide a probability of outcome. Now a review of headaches. Primary headaches: migraine, a vascular headache; tension, most common type; cluster, a severe vascular headache; cranial arteritis, inflammatory cause of a headache in the older population, especially in the age group over 70 years of age. Secondary headaches: related to brain tumor and aneurysm, related to a subarachnoid hemorrhage, related to a stroke, related to hypertension, related to meningitis, related to head injury. Medical management for headaches includes, for cluster headache, 100% oxygen times 15 minutes, ergotamine tartrate, Imitrex, steroids, ganglion block. For cranial arteritis, steroids and analgesic. For migraine, tryptphans, hydrate patient, give oxygen. For tumor, which causes a secondary headache, surgical procedure. Review of brain tumors. Brain tumors are classified according to the tissue or area affected. Meningiomas, 20% of all primary brain tumors. Glioblastoma multiforme is the most common and deadliest primary malignant brain tumor in adults. The most prevalent brain tumor for children is the low-grade pilocytic astrocytoma, accounting for 17.7% of tumors for children ages 0 to 14 and 11.2% for children ages 15 to 19. Manifestation of brain tumor: motor dysfunction, weakness, paralysis, possible seizures, papilledema, edema of the optic nerve, vomiting secondary to irritation of the vagus center and the medulla. Manifestations of a brain tumor include increase intracranial pressure, occurs as a result of any one of skull components increasing in volume. Generalized symptoms reflect increased intracranial pressure. Enlarging tumor compresses the brain, causing headache, nausea, and vomiting. Diagnosis of a brain tumor includes CAT scan, MRI, which is much better actually than a CAT scan at diagnosing brain tumor, arteriography, EEG, endocrine studies, transcranial Doppler studies. Treatment of a brain tumor: under medical management, surgery, chemotherapy, radiation, stereotactic surgery. Medications would include steroids and anticonvulsants. Brain tumors post-op sequelae: SIADH, low urine output, hyponatremia, weight gain. Treat with fluid restrictions and sodium replacement, diuretics, and lithium. Brain tumors post-op sequelae: diabetes insipidus, decreased antidiuretic hormone, polyuria with urine-specific gravity less than or equal to 1.005, polydipsia. Treat with fluid management and vasopressin. Now for a review of brain infections. Pathogens enter the central nervous system via crossing the blood-brain barrier or by direct invasion. These infections are further classified by the structure involved. If the brain tissue is affected, it's called encephalitis. If the meninges are affected, it's called meningitis. If the spinal cord is affected, myelitis. The brain and spinal cord, encephalomyelitis. Some classic clinical manifestations of brain infections include nuchal rigidity, stiff neck, which is an early sign, high fever, altered level of consciousness, severe headaches. Treatment of brain infections. In acute meningitis, regardless of presentation, a lumbar puncture and cerebral spinal fluid examination are indicated to identify the causative organism, and in bacterial meningitis, the antibiotic sensitivities. CAT scan of the head should be performed before LP if indicated. If no mass effect is present on the head CAT scan, the lumbar puncture is performed to obtain microbiology studies. The performance of radiographic imaging should not delay the initiation of empiric antimicrobial therapy. Such therapy should be initiated before head CAT scan if indicated. It is vital to begin treatment as early as possible in the disease course. Delay may contribute significantly to morbidity and mortality. In acutely ill patients, antibiotic therapy should be initiated promptly. In many of these cases, one should strongly consider giving adjunctive dexamethasone before the first antibiotic dose, or at least along with the dose. Treatment of brain infections. The patient's condition and ED organization may warrant 8 to 12 hours of watchful waiting. followed by re-examination of the cerebral spinal fluid. This should be done sooner if the patient's condition deteriorates. If initial granulocytosis changes to mononuclear predominance, CSF glucose remains normal, and the patient continues to look well, the infection is most likely not bacterial. Treatment of complications of brain infections. Systemic complications of acute bacterial meningitis must be treated. Include the following: hypotension or shock, hypoxemia, hyponatremia from syndrome of inappropriate antidiuretic hormone secretion, cardiac arrhythmias and ischemia, stroke, exacerbation of chronic disease. Now for a review of seizure disorders. Definition. A seizure is an episode of abnormal motor sensory, autonomic, or physic activity resulting from sudden excessive discharge from cerebral neurons. Most are sudden and transient, can be partial or involve whole brain. The energy generated overcomes the inhibitory feedback mechanism. International classification of seizures. Seizures can either be partial or generalized. Partial seizures involve one hemisphere. They could either be simple or complex. Simple, consciousness not impaired. Complex, consciousness is impaired. Generalized seizures involve both hemispheres, and generally there is a loss of consciousness. Tonic-clonic, atonic, which are drop attacks, status epilepticus, continuous seizing for more than a minute, absence seizures, staring spells, myoclonic, involving one side of the body, or febrile seizure, are some types of generalized seizure manifestations. Your assessment of the patient who has had a seizure or has seizure disorder should include: what type of seizure was it? How long does it last? Was there an aura? What are the precipitating factors? Is the patient postictal? What are the current medications the patient is taking? Management of a patient who's having a seizure. Loosen restrictive clothing. Do not force anything in the mouth. Do not restrain. Administer Ativan or Valium. Stay with the patient and document the time and how long the seizure lasted. Further management of a patient with a seizure disorder includes: protect for injury. Number 1, provide safety. Ensure airway, oxygen, suction equipment available if you're in the hospital. Ensure that there's IV access. Again, that's for the hospitalized patient. Some common drugs used to treat seizure disorders include Tegretol, Neurontin, Gabatril, phenobarbital, an old drug, clonazepam or Klonopin, diazepam or Valium, Keppra as an adjunct to treatment. Now for a review of cerebral vascular accident, brain attack, stroke. All three names are synonymous. This is a functional abnormality of the central nervous system that occurs when the blood supply is disrupted. Stroke is the primary cerebral vascular disorder and the third leading cause of death in the United States. Stroke is the leading cause of serious long-term disability in the United States. Some key points about a stroke. Results from a disruption in normal cerebral blood flow to the brain related to ischemia, hemorrhage, or embolism. Strokes are considered a medical emergency. Mortality and degree of disability can be decreased by rapid recognition and intervention. Major risk factors include hypertension, diabetes, heart disease, hyperlipidemia, and smoking. Major risk factors for stroke include modifiable and non-modifiable risk factors. Modifiable risk factors include hypertension, cardiovascular disease, elevated cholesterol, obesity, diabetes, oral contraceptive use, smoking and drug and alcohol abuse. All of these can be modified or changed. Non-modifiable risk factors. Age over 55. The risk of stroke doubles every decade after age 55. Male gender, African American, race. Modifiable risk factors. Tobacco use. Tobacco use doubles the risk among smokers compared to non-smokers. 50% reduction of risk with cessation of smoking. Patient education for smoking cessation should be offered. Using the 5 A's to evaluate and help patients. A is for ask, assess, advise, assist, and arrange. Stroke warning signs. Sudden numbness or weakness in the face, arm, or leg, especially on one side of the body. Sudden trouble walking, dizziness, loss of balance or coordination. Sudden severe headache with no known cause. Sudden trouble seeing in one or both eyes. Sudden confusion, trouble speaking or understanding. Further assessment of a patient having a stroke should utilize the FAST acronym. FAST equals face numbness or weakness. Is the smile equal? A equals is the arm numbness or weakness to one side of the body. S is the speech slurred or is there difficulty speaking or understanding the patient? T, time to call immediately 911 and note the time the symptoms started or the last time the person was seen normal. Further assessment includes the FACE acronym. Here's how it works. FACE. Ask the person to smile. Does one side of the face droop? Arms. Ask the person to raise both arms. Does one arm drift downward? Speech. Ask the person to repeat a simple sentence. Are the words slurred? Can the patient repeat the sentence correctly? Time. Get the affected person to a hospital right away to receive the most effective treatment. Medical management during an acute phase of a stroke. Prompt diagnosis and treatment is imperative. Assessment of the stroke using the NIH scale. Is thrombolytic therapy indicated based on your CAT scan? Review your criteria for tissue plasminogen activator, Retivase, or Activase. These are other types of clot busters used most commonly in the emergency room. Review IV dosage and administration based on the weight of the patient. What patient monitoring is involved? Remember, the most important side effect of thrombolytic therapy is the potential for bleeding in all orifices of the body. Management of ischemic stroke. Interventions, ABCs, airway, breathing, circulation, blood pressure management, critical to prevent further bleeding. Correct hypo or hyperglycemia. Seizure prophylaxis, if indicated. Prevent hypothermia, another complication of ischemic stroke. Prevent dehydration. Prevent other complications that might be occurring as a result of thrombolytic therapy. Further medical management during the acute phase of a stroke. Elevate the head of bed unless contraindicated. Remember that 30 degrees. Maintain airway and ventilation. Provide continuous hemodynamic monitoring and neurologic assessment. National Institute of Health Stroke Scale helps to determine level of stroke severity. 0 to 1 normal, 1 to 4 minor stroke, 5 to 15 moderate stroke, 15 to 20 moderately severe stroke, greater than 20 severe stroke. Predicts outcomes less than 14, 80% good outcome, greater than 20, 20% good outcome. Stroke protocol. CAT scan to rule out intracranial bleed or hemorrhagic CVA. Door to CAT scan time, 25 minutes. Remember the golden hour of treatment. That means the patient should be evaluated, vital signs, CAT scan, further assessment, all done within an hour, and a plan to either administer or not administer TPA should be within that first hour of treatment. Review the history for contraindications for thrombolytic therapy. The NIH stroke scale should be utilized. If it's greater than 22 in patient, that determines there is a severe neurological deficit, and these patients are at higher risk of intracranial bleed. If the blood pressure is greater than 185/110, nitroglycerin paste or labetalol 10 to 20 milligrams IV push should be given. If the blood pressure remains elevated, cannot give the Activase TPA or Retaplase. TPA or tissue plasminogen activator for ischemic stroke should be given at a range of 0.9 milligrams per kilogram. The maximum dose of less than or equal to 90 milligrams. 10% of the total dose is administered as an IV bolus over 1 minute. The remaining 90% is infused over 60 minutes. Hemorrhagic stroke, caused by bleeding into brain tissue, the ventricles, or subarachnoid space, may be due to spontaneous rupture of small vessels, primarily related to hypertension. Subarachnoid hemorrhage due to a ruptured aneurysm is another cause, or an intracerebral hemorrhage related to arterial venous malformation or intracranial aneurysms, or medications such as anticoagulants. Management of hemorrhagic stroke or aneurysm. Stat Neuro surgical consult, MRI or MRA, to further evaluate the nature of the bleeding. ICU admit, angiography. Surgical clipping or embolization are possible treatments for this type of stroke. Now for a review of Parkinson's disease. This is a progressive, degenerative, neurological disease characterized by resting tremors, bradykinesia, and muscle rigidity. It is the fourth most common neurodegenerative disease. The mean age of onset is in the 50s, or fifth decade of life. It affects more men than women. Pathophysiology of Parkinson's. Atrophy of the brain neurons of the substantia nigra that produce dopamine, or neurotransmitter that helps regulate nerve impulses involved in motor function, is what occurs. Dopamine production decreases. ACH is no longer inhibited by dopamine. ACH stands for acetylcholine. Loss of dopamine receptor sites occurs. Neurotransmitter imbalance disrupts coordinated movement. Manifestations of Parkinson's disease. 3 cardinal signs of Parkinson's disease include tremor, rigidity, bradykinesia. Resting tremor. Resting tremor characteristically disappears with purposeful movement. Resting tremor is the presenting complaint in 75% of patients, usually seen first in the lips, chin, and tongue. Pill rolling. Non-intention tremors that affect hand movement. Rigidity. Muscle rigidity produces a jerky motion, most observable at the distal upper extremity. Complaining of stiffness versus rigidity. Complaining of shoulder pain, common complaint in Parkinson's patients. Bradykinesia, profound slowness, beyond normal for age. All striated muscle is eventually affected. Extremities, trunk, ocular, facial, swallowing, chewing, talking. Hypokinesia, diminished movement, decreased blinking, dysarthria, slowed speech, mask-like appearance. Freezing phenomenon, transient inability to perform active movement, feet glued to the ground. Bradykinesia, slow shuffling gait, loss of balance, loss of arm swing, no protective arm extension when falling. Micrographia, small slow handwriting. Dysphonia, soft, slurred, low-pitched speech. Dysphagia, drooling, risk for aspiration. Loss of postural reflexes. Stooped posture with propulsive gait. Postural gait problems. Flexed posture at multiple sites. Rocking to get out of chair. Loss of postural reflexes. Shuffling gait. Loss of balance. Diagnostics. PET scan evaluates levodopa uptake and conversion to dopamine. History and physical. Most importantly, looking at the presence of 2 of the 3 cardinal manifestations: tremor, muscle rigidity, and bradykinesia. CBC, basic metabolic panel. Drug screen, to evaluate other contributing factors. Upper GI series to look for delayed emptying, distension, megacolon, and constipation. Levodopa, mainstay of treatment for Parkinson, precursor of dopamine that crosses the blood-brain barrier where it is converted to dopamine, almost always given in combination form with carbidopa as a fixed combination drug, Sinemet. Carbidopa decreases the amount of levodopa needed to reach a therapeutic level in the brain. The dosage of levodopa can be decreased, reducing adverse side effects. Pharmacological therapy, levodopa-carbidopa. Carbidopa decarboxynase inhibitor, which helps prevent wasting of the levodopa in the periphery and blocks nausea and vomiting. It's the most effective treatment. Benefits wane only after 5 to 7 years, prompting the need for drug holidays. The highest level of motor symptom control. Low dose patients can be on Sinemet combination for 30 years and be ambulatory. Some further information about Sinemet. It's a combination drug. 25 to 100 is the lowest dose. Indicates 25 milligrams of carbidopa and 100 milligrams of levodopa. Some of the side effects include dyskinesia, involuntary movements, nausea, vomiting, constipation, daytime sleepiness, vivid dreams, visual hallucinations, and orthostatic hypotension. Also the syndrome of on-off, where they're able to start movements and the movements stop and then they start again. Other dopaminergics used to treat Parkinson's: amantadine, bromocriptine, pergolide, pyraxenol, Requip, also used as adjunct to levodopa. Dopaminergics actions: increase the level of dopamine in the substantia nigra, directly stimulate the dopamine receptors in the area, help to restore the balance between the inhibitory and stimulating neurons. Indications: for relief of the signs and symptoms of idiopathic Parkinson's disease. Dopaminergics: patients younger than 70 without cardiac problems, dopamine agonist therapy is a reasonable first choice for medication. Start low, go slow, with dose titration to avoid side effects. Effect may take several weeks to detect, to several months. Pharmacokinetics: well absorbed from the GI tract and widely distributed in the body. Metabolized in the liver and peripheral cells, excreted in the urine, and it does cross the placenta. Anticholinergics: control rigidity and tremor, blocks excitatory action of acetylcholine, can be useful in treating early symptoms, especially tremor. Action: block the action of acetylcholine in the CNS to help normalize the acetylcholine dopamine imbalance. Indications: treatment of Parkinson's, relief of extrapyramidal symptoms. Pharmacokinetics: absorbed from the GI tract, peak in 1 to 4 hours, metabolized in the liver, excreted by cellular pathways, also crosses the placenta and enters breast milk. Medical management: the goal is to control symptoms, maintain the highest level of functioning possible. The use of pharmacology to treat mild to moderate symptoms. Selagine and MAO inhibitors block the enzyme that break down dopamine and are used as adjuncts to therapy with levodopa. Monitor for hypotension and insomnia with the use of these drugs. Nursing priorities: risk for aspiration, risk for falls, alteration in nutrition, alteration in elimination, risk for infection, alteration in sleep, alteration in mobility or immobility. There are many knowledge deficits related to the disease, medication use, physical therapy, speech therapy, safety, ineffective coping related to depression and dysfunction. Multiple sclerosis. It is a chronic, degenerative, and progressive demyelinization of the central nervous system. Cause unknown, autoimmune, familial, environmental. Some genetic predisposition has been researched. more common in northern climate, more common in ages 20 to 40. Clinical manifestations vary. Symptoms depend on area of damage, weakness, loss of balance, fatigue, speech, poor coordination, and respiratory problems. Try to keep the person active, exercise, prevent elimination problems, tapping and cupping and deep breathing for respiratory issues. Multiple sclerosis. The general pattern of multiple sclerosis is remissions and exacerbations. Symptoms recur including fatigue, weakness, numbness, difficulty in coordination, loss of balance, pain, and visual disturbances. Medical management includes disease-modifying therapies such as the ABC drugs, Avonox, Betstarin, Copaxine. IV methylprednisone is utilized. Symptom management of muscle spasms, fatigue, ataxia, and bowel and bladder control are very important. There is no cure. So what is the hallmark of multiple sclerosis? The process of demyelinization. Demyelinization of the myelin sheath. In multiple sclerosis, the myelin sheath, which is a single cell whose membrane wraps around the axon, is destroyed with inflammation and scarring, and this is the root of all of the sequelae in MS. Further manifestations of MS include weakness and paralysis of limbs, the trunk, and the head, visual changes, blurred vision, diplopia, partial blindness, ataxia, intention tremors to differentiate between resting tremors and Parkinson's, fatigue, the overwhelming hallmark of MS, spasticity of extremities, abnormal reflexes. And as you can see on the right hand side, there's a little cartoon exemplifying these manifestations. Diagnosis, labs. MRI is the primary test for diagnosis. CAT scan can be utilized, lumbar puncture, EEG, PET scan, and obviously a neuro consult. Planning the care of the patient with multiple sclerosis or MS. Major goals may include promotion of physical mobility, avoidance of injury, achievement of bowel and bladder continence, promotion of speech and swallowing mechanisms, improvement in cognitive function, development of coping strengths or mechanisms, improved home maintenance, adaptation to sexual function. Interventions utilize a collaborative approach, usually through the MS Society. Coordinate and refer as needed to healthcare services, social services, speech therapy, physical therapy, counseling services, and home care services. Activity and rest. Implementation of a program of activity and daily exercise. Implementation of relaxation strategies, coordination and muscle stretching exercises, and walking. Avoid very strenuous activity and extreme fatigue. Management of MS is going to include medications, as mentioned earlier, such as steroids, ACTH, Imuran, Sanimune, interferon. The ABC drugs still today are the mainstay of treatment. All were approved in 1996. All are injectable. Plasmapheresis, anticholinergics, muscle relaxants, baclofen, Valium, and Dantrum. Guillain-Barré syndrome, medical emergency, acute, rapid, ascending weakness, paresthesias. Risk factors include illness, upper respiratory infection, GI infection, viruses such as cytomegalovirus or Epstein-Barr have been implicated in Guillain-Barré syndrome. Vaccination such as the H1N1 has been implicated in Guillain-Barré syndrome. Recent surgery. There is an 85% recovery rate and the treatment is supportive. In general, there are 3 stages to Guillain-Barré. The initial period, 1 to 4 weeks, onset of symptoms until no further deterioration. Plateau period, several days to 2 weeks, no changes. Stable period, Recovery period 4 to 6 months and up to 2 years to return of muscle strength. These patients might end up on a ventilator due to the ascending paralysis that occurs in Guillain-Barré, which paralyzes the respiratory muscles. This is one of those little cartoons that pull Guillain-Barré syndrome together, combining the risk factors, progression, and assessment findings into one slide. Diagnosis of Guillain-Barré is done by physical assessment, EMG, looking at a white blood cell count, and lumbar puncture, which shows increase in protein with cerebral spinal fluid. Medical management includes intubation, anticoagulation, plasmapheresis, EKG monitoring, blood pressure monitoring, urinary retention monitoring with insertion of a Foley catheter. Nursing management includes assessment of the respiratory status, maintain pain and airway, vital signs, cranial nerve function assessment, pain level assessment, monitoring for possible complications of plasmapheresis, which are hypovolemia, hypokalemia, and hypocalcemia. Head of bed should be elevated. Tapping and cupping and deep breathing are important. Incentive spirometry is important. Prevent complications of immobility. Promote adequate nutrition. Improve communication. Help to decrease fear and anxiety by giving information as needed. Teaching regarding favorable prognosis is very important for patients to hear. Course of disease. Respiratory failure is the biggest complication of Guillain-Barré. Can resolve within 2 years. Most patients can have a complete recovery. 85% will recover with minimal symptoms, and residual effects can occur in certain patients. In conclusion, I hope this review has been helpful. Review all your PowerPoints, soft chalk, PrepU, and HESI materials. Review delegation and prioritizing. Review scope of practice of the LPN, the PCA, or unlicensed personnel. And review all quizzes that have been administered. Good luck!